I'm Angie Dashel. I'm the Marketing Director for Doctor's Data. In our webinar today, Dr. Ferris will be speaking about testing hormone metabolites and neurotransmitters, as Gina mentioned. You'll learn more about the Doctor's Data neurotransmitter profiles, as well as the HUMAP, the Hormone and Urinary Metabolites Assessment Profile. Lylen Ferris attended Davidson College in North Carolina, where she obtained a BA in Cultural Anthropology and a minor in Art History. After traveling extensively and witnessing different cultures and ways of thinking, Dr. Ferris realized naturopathic medicine was her calling. She completed her pre-medical training in Australia and returned to the United States to attend medical school at the National College of Natural Medicine in Portland, Oregon, where she trained as a general practitioner and tailored her studies to focus on women's health. Her love of teaching began during her advanced women's health residency, where she taught clinical education and gynecology classes while mentoring students. Dr. Ferris has continued to teach other medical professionals in the U.S. and around the globe at numerous functional medicine conferences, online webinars, podcasts, and seminars. Dr. Ferris offers a deep knowledge and enthusiasm for teaching hormone and neurotransmitter biochemistry, including research, testing, and optimization. Dr. Ferris is also currently the senior staff physician for Doctor's Data, where she leads the team of physicians focusing on educating practitioners worldwide. She also maintains a clinical practice in Portland, Oregon, and her focus has grown to include males and females of all ages. And now I will hand it over to you, Dr. Ferris.
Thanks, Angie, and hi, everybody. Thanks for joining me today. So I'm going to be talking about testing hormone metabolites and neurotransmitters from the same sample, which can provide us with extensive data to help our complex patients. Because patients are complex, and we know that similar symptoms can be the result of many different and individualized neurotransmitter and hormone imbalances. Mental health problems aren't isolated to the brain alone. There are many factors that affect our mental well-being, and so by assessing neurotransmitters and reproductive and adrenal hormones, we can get a more well-rounded understanding of how things like nutrition, digestion, inflammation, stress, metabolism, and methylation can contribute to the symptom picture. So in general, we think it's really important to test to determine which therapeutics are appropriate. So let's start today's lecture I want to introduce you guys to our HUMAP, and that's our shorthand for our new hormone and urinary metabolites assessment profile. So this is an image of the front page of the HUMAP. This is our summary page. It gives you a snapshot of all of the findings in the deeper report. So it's sort of the cream that rises to the top, what we have determined to be the most clinically actionable information, and that was decided after speaking with clinicians who utilize this tool and also by reading the literature and trying to determine what is the most well-researched information that this test provides. So with this test, not only can you look at all of the sex hormones and their metabolites, but you also are given ratios that help you assess enzyme function. And you can also get a look at the diurnal cortisol pattern, which can help you fine-tune HPA axis treatment strategy, and also catecholamines that are involved in the stress response. We know that neurotransmitters and hormones don't exist in a vacuum, which is why adding neurotransmitters to this hormone profile can be really helpful because they can influence one another. There are two levels of urinary neurotransmitter assessment that Doctor's Data offers: the neurobasic profile, which you see here on the left, and the comprehensive neurotransmitter profile, which you can see on the right. The neurobasic profile measures 9 neurotransmitters. It's sort of the most clinically researched neurotransmitters. It's a great test to use if you're new to neurotransmitter testing. It's also a great option if you're monitoring therapeutic interventions because you've got some of the most impactful like serotonin and dopamine and norepinephrine here on this test. The comprehensive neurotransmitter profile includes all of the markers tested on the neurobasic as well as racemines, metabolites, and other markers like tyrosine and taurine. So it gives you a little bit of a deeper dive. So here's our roadmap to today. I'm going to introduce you to the HUMAP test, talk about what are these urinary hormone and metabolites, and why might you be interested in testing them? And also talk about what's involved in the metabolism of these hormones. Some of the major hormones and metabolites that we think you might want to pay attention to in your practice will be discussed. We'll also talk about 8082GG, which is an oxidative stress marker. And then we'll talk about some of the influences of hormones on neurotransmitters and vice versa. So essentially the benefits of testing these together. So without diving deep into the laboratory science here, I did want to give you a quick overview of the lab's testing methodologies. So Doctors Data tests liquid urine samples via liquid chromatography, tandem mass spectrometry. So that's LC-MS-MS. So the LC separates the hormones in the liquid sample, and the MS verifies each hormone identity based on molecular weight. The combination of LC and tandem mass spec allows for extremely sensitive and specific hormone measurements. So a few things to note here about collection. So this information is included in the instructions, which are inside every collection kit. Patients are instructed to collect urine at dinner time, at bedtime, and then when they wake up the next morning and 2 hours after waking. There's also a tube that's optional, but if patients wake in the middle of the night to urinate, we suggest that they collect that sample as well. So because just remember that any urine that we're flushing away is data that we can't test. So as much urine as can be collected in these 4 to 5 samples is recommended. If a patient misses a sample, you certainly can have them collect over several days rather than consecutive collections. But if they miss a collection, having them to collect as close in time to the other samples as possible is recommended. So you can see here on the left, this is the front page of the instructions that are included in the collection kit. And if your patient zaps that little QR code with their phone, they will have access to this handout, which is called Best Practices for HUMAP Specimen Collection. It lives on the website, but again, it's also accessible to patients via this QR code. And this contains information to help them collect properly, so that the results that you get reflect the best information possible. Please ask your patients to carefully read the preparation section because there is important information here about which data to collect for cycling women. And then we also give important information about dosage intervals for different routes of administration for hormone therapy. There's also information here about foods or substances to avoid before testing. Because there are some foods that can impact catecholamine secretion, serotonin secretion, but also cortisol, if we're thinking about stimulant things like caffeine, nicotine, or even exercise. So all of this is laid out in this document as well as the instruction booklet. So it's all here. I do want to note it's not necessary to limit water consumption for this test. And that's really great for nursing moms or people who just sort of are thirsty and find that challenging. So what are urinary hormones and metabolites? Well, what you will see on any urinary hormone and metabolite report will be the measure of the unconjugated hormones. So this is when we're talking about things like estradiol, progesterone, testosterone, as well as the conjugated metabolites of these hormones that are leaving the body. So remember that hormones are fat soluble, not water soluble. And so to be found in urine, they have to be conjugated to a side arm that makes them water soluble. So these are things like glucuronides or sulfides, and this facilitates movement through the body so that they can be eliminated. So again, the first page of the HUMAP is a summary page, and I know this looks busy, but it's really, we created it because we wanted to provide you with the most relevant markers on page 1. Like I said before, the summary page highlights all of the most clinically actionable information in the report. Our aim was to give you as much information at a glance as possible in the first 2 pages of the report. I'm going to get to the second page momentarily, but we know that you guys don't have a lot of time on your hands. So we're trying to give you a lot of information at a glance. So I'm going to walk you through each section of this summary page so that it doesn't feel so daunting. So important clinically relevant markers are color-coded to respond to an individual's imbalances, which provides you with this at-a-glance format on the summary page. So dark blue indicates a marker is below range down here. Red is above range, and everything from yellow to light blue is within the reference interval, but light blue is suboptimal and yellow is upper range. The same 15 analytes will be populating for every patient on the half moon, but the placement of them will be patient dependent. So the markers that are going to always populate here are estradiol, estrone, estriol. The ratio between 4-hydroxyestrone to 2-hydroxyestrone, progesterone, as well as alpha and beta pregnenolone, which are progesterone's two major metabolites, allopregnanolone, DHEA plus DHEAS, so the sum of the two, testosterone, 5-alpha DHT, the amount of cortisol secreted over the day, the amount of cortisone secreted over the day, metabolized cortisol, and that oxidative marker 8-hydroxy-2-deoxyguanosine. You can also see that there is a little letter here next to each of these words, and so that corresponds to the neighborhood it belongs to. So for instance, if you didn't realize that allopregnanolone was a progesterone, then you would know that that would be found in the progesterone section. If you didn't realize testosterone was an androgen, then you know you could go to the androgen section to find out more about that analyte. So here you can see 3 different patients and how the same 15 analytes are populating at different spaces on these half moons based on their individual imbalances. So I really like this heat map approach where you can see at a glance patient 1 is pretty depleted. Most of their markers are below range, whereas with patient 2 and 3, there's more of a sort of a even spread between things that are too much of something or too little of something. So in the top right of the summary page, we have this estrogen section. So here we're highlighting the 2-hydroxy, 4-hydroxy, and 16-hydroxyestrone percentages. So this is laid out in grayscale, and you can see that the reference range is represented by these dotted lines, and where the patient falls here is represented by the dark line. Here on the left, we've got the 2-hydroxy pathway for both estrone and estradiol, and the 4-hydroxy pathway for estrone and estradiol. And here's the 16 pathway. So phase 1 shown here. Phase 2, which is the methylated step, 2-methoxyestrone and estradiol, 4-methoxyestrone and estradiol. And then this is the methylation activity that's showing you just the estrone side. So again, here we're highlighting estrone just because most of the literature is focused on estrone. We think it's really beneficial to also follow the estradiol, and there'll be more information about that in the estrogens neighborhood deeper in the report. But here on the summary page, we're showing you methylation of the estrone metabolites. So all of that is laid out here for you. Now, remember, red means abundance, doesn't necessarily mean bad. So with methylated factors, or here methylation activity, it's actually a good finding because this means there's a lot of methylation activity for these metabolites, which is what we would want. All right, so here we've got these 2 different patients, just again to emphasize how it might look different based on their own individual imbalances. Now we'll move to the little corticoids section. We here on the summary page are plotting cortisol and cortisone on the same graph, so you can quickly identify their relationship to each other. Cortisol is the solid line and cortisone is the dotted line. And you also have this dial on the left that is noting whether the patient is favoring cortisol or cortisone. I do want to note that this graph is not to scale because cortisol and cortisone do have different reference ranges. So to see graphs that are more precise in terms of the actual diurnal pattern of these markers, you're going to want to go into the corticoids neighborhood section. But here on the front page, you can at a glance see if the patient is favoring cortisol or cortisone. And then the last section on the summary page is the key relationships. So some of the information that urine testing provides that other mediums can't is the movement of analytes from one to another, which allows us to extrapolate information about enzyme activity. So there are 3 areas highlighted here on the summary page. 5-alpha reductase. Now on the summary page, this is highlighting the androgens neighborhood. 5-alpha reductase activity is actually active in 3 different neighborhoods, but it's the androgens that typically are problematic when we have movement into 5-hydroxy testosterone. The DHT is a really potent testosterone metabolite and can be problematic in terms of driving symptoms. So here is a way to see at a glance if the patient is preferring the alpha activity, which is the one that can be clinically problematic, or beta. So in this case, this patient is preferring the safer beta metabolism. Then here we're highlighting aromatase activity. So again, this is, as you know, the movement of these androgens, testosterone and androstenedione, into the estrogens, estradiol and estrone. So you can see here maybe a little bit of aromatase activity with the androstenedione, but really not a lot. This is pretty neutral. And then this marker of COMT or methylation activity is sort of another way to look at the methylation of the estrone metabolites. So here we're looking at the 4-hydroxyestrone. So the 2 pathway is considered to be the safer pathway. The 4 pathway is a dangerous one. So here we're showing you the ability of this patient to methylate what is the potentially most carcinogenic metabolite, those 4-hydroxyestrone metabolites. And because this patient is favoring methoxyestrone, that's a good finding, because the methylated metabolites have less carcinogenic potential. Okay, on page 2 of the report, you can see the entire steroid hormone cascade. So this, again, is dynamic and color-coded and displays actual patient results, so that at a glance, you can see which markers for this particular patient are high or low, within range, upper range, or suboptimal. So here you can see 3 different patients, each with colors that correspond to their individual highs and lows. So have you heard that saying you can't see the forest for the trees? I think it's applicable here. I do want to caution everyone not to get too wrapped up in fixing every analyte that may be out of the expected reference range. That's really not the purpose of this test. I think it can be helpful to actually sort of take a step back and look at the report as a whole. So when we do take a step back, let's also think about this dynamic steroid cascade as a river. This helps me in my mind anyway. So we can think of cholesterol as sort of being the start of this river, and then everything is flowing downstream. So being able to look at this steroid hormone cascade with color coding allows us to assess whether things are flowing. Are they flowing well, or are there blockages? So where we have excess markers, this is sort of acting like a dam. Things are getting slowed here and may not be moving downstream as well. So we can assess, are things moving? Are there slow areas or faster areas? This is the type of question I think that's helpful to ask ourselves when we're utilizing a report with this much information. But we're going to get into more of the details of this as we move forward today. I do want to note that in a postmenopausal woman, if supplementation is reported, premenopausal ranges will populate on the last page of the neighborhood in question, so that you can see where she falls in relationship to premenopausal ranges. So the goal of HRT or BHRT is not necessarily to move a postmenopausal woman into a premenopausal range, but you might find that her hormones and metabolite levels under the influence of HRT are actually higher than the postmenopausal levels would be. And so we think including this premenopausal information allows you to consider both ranges. But do remember that the color mapping that you see, the reds, the yellows, the blues, et cetera, will be reflective of her postmenopausal status. Okay, when we think about this big report, it can be helpful to think about it in these smaller neighborhoods. So there are 4 main neighborhoods: the progesterones, the corticoids, the androgens, and the estrogens. And we're going to now walk through each one. We'll start with progesterones. So here's a little screen grab of the progesterone neighborhood. So some of the highlights here are our ability to test progesterone itself, the 5-alpha and 5-beta pregnenolone, which are the primary metabolites of progesterone, and then allopregnanolone. Metabolism occurs primarily in the liver, but also in other tissues. So like I said, the major metabolites here are 5-alpha PD and 5-beta PD. We also can see some intermediates for the corticosteroids here. So what this allows you to do is sort of see, is progesterone moving towards cortisol and cortisone, and the mineralocorticoids as well. 5-alpha pregnenolone and 5-beta pregnenolone are these metabolites of progesterone. They are useful as an indirect measurement of progesterone in the body. So our testing, some labs will give you a sum of these two metabolites to extrapolate what the progesterone levels are. The doctor's data testing methodology is sensitive enough that we're actually able to test progesterone itself, which is really helpful. But because progesterone is so fatty, there's not a lot of it found in the urine because of just steroid hormone chemistry. And so looking at these metabolites can also be helpful, not only because it gives an idea of what's present, but because you can see how progesterone is moving through the pathway. That river, is it flowing downstream? And then one of my favorite things about this doctor's data report is that we are able to measure allopregnanolone. Allopregnanolone is an important progesterone metabolite because it can cross the blood-brain barrier and interact with GABA receptors. So there's a lot of good research that indicates that there's a clinical utility of this. We can use it for mood disorders, for depression, for anxiety. Allopregnanolone, because it attaches to GABA receptors, works in the same way that a benzodiazepine might. So you can see how clinically that could be really beneficial for you. You do want to use with caution in something like PMDD because some patients can have a paradoxical reaction from it. But in general, I find it works really, really well. Now, if you want to try to push allopregnanolone, you can give progesterone orally. Because there's a big first pass effect with oral progesterone, you get a lot of allopregnanolone created. And so that can help you have these therapeutic effects. And then you can monitor. Once a patient starts oral progesterone therapy, you're able to test their urine again to see, are they in fact moving a lot of this progesterone into allopregnanolone? Am I getting the clinical response that I want to see? Okay, now we will move into the corticoids neighborhood. So here you can see some of the information we showed on the summary page, but also this is an image from the interior of the report, the corticoids neighborhood. So you can see now the cortisol and cortisone are each graphed on their own graphs using the correct units. So we're able to see the relationship of cortisol and cortisone. We're able to see the diurnal pattern of the cortisol and cortisone, and we can also get information on the metabolites of these markers. Now, looking at the relationship between cortisol and cortisone can be really helpful. So remember, cortisol is our active form. Cortisone is the storage form. So the enzyme that converts cortisol to cortisone and back again is the 11-beta HSD enzyme. It's most active in the kidney. The 11-beta HSD1 enzyme creates more cortisol. So it's converting cortisone, the inactive form, into cortisol, the active form. This is usually a busy enzyme if your patients are obese, if there's inflammation, if there's hypothyroid or metabolic syndrome. If the patient is favoring the HSD2 direction, we will typically see more cortisone in relationship to cortisol. Now, I do want to note that it is a normal finding for people to favor cortisone. This is because urine is created in the kidney, and we know that the HSD2 form of this enzyme is most active in the kidney. Now, we do favor cortisone because cortisol can activate mineralocorticoid receptors and cause hypertension, which is physiologically not something that we would want to see. And so that's why generally people favor cortisone. If you find your patient is favoring cortisol, it likely means there's some inflammation, thyroid issue, et cetera, that you're going to want to work up. Now, when I learned about this, it finally all clicked for me. This is the mechanism behind licorice and the caution to use it in patients with hypertension, because licorice is helping to support the activity of the HSD1 enzyme. So it's moving more cortisone into cortisol, and that cortisone can trigger those mineralocorticoid receptors as well. So just a little aside, but I thought that was really interesting when I finally sort of understood the mechanism of why licorice can contribute to hypertension. So if your patient is favoring cortisol, that's probably a problem. How do we make that enzyme slow down so that we're favoring cortisone? Well, again, if you can identify sources of inflammation, if the patient is insulin resistant, if they have central adiposity, those are all things that we can target to try to slow the activity of this enzyme. And then you can see other things listed here. Physical activity can do it. And then there's some herbs and other substances that can help to slow the activity of this enzyme. So as we move through this lecture, you're going to see that we have very extensive lists of things that can contribute to enzyme function, either upregulate or downregulate an enzyme. I'm not going to read all through these lists today, but you will be getting a copy of these slides, so you'll have that information as a reference. So in addition to the cortisol and cortisone relationship in this neighborhood, you'll get information on metabolized cortisol. Now, weirdly, the shorthand for cortisol is a capital F, and the shorthand for cortisone is a capital E. And so that's why the metabolites of these markers are THE and THF. So the metabolized cortisol is actually the sum of the metabolites of cortisone and cortisol. Essentially, we're sort of looking at active plus potential. And when you look at that in the metabolites, it's a measurement of what the body has utilized. So metabolized cortisol, that's sort of the industry standard naming for this marker, but in fact, it's the addition of cortisol and cortisone. The other marker you can see here is the ratio between cortisol and cortisone metabolites. So that's the sum of the 5-alpha and 5-beta THF versus the metabolite of cortisone. So if we've got high levels of metabolized cortisol, there may be increased cortisol clearance due to overproduction of cortisol, but it's also influenced by obesity, insulin resistance, inflammation, and hyperthyroidism. If we see low metabolized cortisol, this indicates there's decreased cortisol clearance. That could be due to hypothyroidism, anorexia, or decreased liver function. And remember, because free levels of cortisol can be converted to cortisone in the kidney before excretion, looking at the metabolites may give clinicians a better idea of overall metabolic preference within the body. Okay, let's move on to the androgens neighborhood. So in the androgens neighborhood, there's a lot of information, but some of the, again, most clinically actionable information might be the aromatase activity, aromatase enzyme, and the activity of the 5-alpha reductase enzyme. So you can monitor those. And one of the ways is by looking at the activity or the amount of the 5-alpha DHT, the dihydrotestosterone, which is that really potent testosterone metabolite. We can also monitor the 5-alpha and 5-beta metabolism relationship. So you're looking at androsterone in relationship to etiolanolone, and that lets you know if the patient is favoring that alpha pathway or that beta pathway. You can also get information about DHEA, DHEAS, and the sum of those two. And looking at the androgens neighborhood can give you information about patients who have concerns that are typical to the androgens neighborhood. So for females, we're often thinking about PCOS or metabolic syndrome. For males, we're often thinking about prostate health because DHT can be so problematic when we think about benign prostatic hypertrophy and even cancer. So the scientific name of the aromatase enzyme is CYP19A1. We know that this converts androstenedione to estrone and testosterone to estradiol. It's particularly active in adipose tissue. There are a lot of other things that can influence aromatase activity, but I think we're all familiar with this idea that in the periphery, aromatase activity is very active in adipose tissue. So testosterone, again, can convert to estrogen via this activity, the aromatase activity. When we have more adipose tissue, typically abdominally, it can increase the activity of aromatase, which increases inflammatory cytokines. So we sort of get this cascade effect. And of course, this is all exacerbated by stress, by alcohol, by carbohydrate-heavy diets, et cetera, et cetera. So these are all things that can activate the activity of the aromatase enzyme. In general, this is something that we would want to slow or downregulate. So these are some ideas of substances or activities that will result in a downregulation of this enzyme. So supplementally, we might consider chrysin or zinc or damiana, grapeseed extract, nettles, etc. But you might also consider, like, is my patient exposed to glyphosate? Maybe they live in a rural community. Maybe they're actually a farmer. Maybe they're just an avid gardener, but they're not using organic methods. Glyphosate can downregulate this enzyme. So there are a lot of things that can influence activity of this enzyme, and we've tried to, based on the research we've done, list as many of them as possible here. So again, the 5-alpha reductase, we are revisiting this enzyme. It's a biggie. It is used in the conversion of testosterone into its more potent form, dihydrotestosterone. Now, DHT has 2 to 3 times the affinity for androgen receptors that testosterone does. So when DHT is there in excess, but even sometimes in normal levels, you can see a lot of symptoms in these patients. So in females, we might see acne, scalp hair loss, hirsutism, and mood changes, mood lability. And then in males, I mentioned the prostate, but also that male pattern hair loss. So to downregulate this enzyme, we might think about things like saw palmetto, nettles, or pygeum. Now, I do want to point out that we might be focused on the androgens neighborhood to downregulate this enzyme's activity because of those androgenic symptoms, but because 5-alpha reductase is also active in the corticoid and the progesterone's neighborhood, you might see inhibition in these neighborhoods as well. So just pay attention that it's not just the androgens neighborhood we're focused on, although clinically that may be what we're thinking about. It could have broader effects than just that neighborhood. To be able to determine if your patient has the preference for alpha or beta, again, there's a ratio that's calculated for you by the lab that's looking at androsterone and etiocalanolone. If they're favoring alpha metabolism, the patients may have more of these androgenic symptoms, and if they're favoring beta metabolism, they would likely have less of these androgenic symptoms. Because DHEA is a prohormone and can function to increase both androgens as well as estrogens, it can be an important part of the hormone story. DHEA is the active form and DHEAS is the inactive form. And adding these together can give practitioners an idea of the total pool of DHEA. And so it may be a better representation for you than just looking at DHEA by itself. So now let's take a look at patients and see what these levels can reveal. So this is a case of a 15-year-old female who had PCOS. Note she had upper range DHEA, elevated testosterone, upper range androsterone, as well as its metabolite 5-alpha AD. And so utilizing urinary testing in this case really helped us elucidate the total impact of androgens in this young woman. And it may be able to give you some peace of mind regarding the androgenic symptoms she was experiencing and ultimately help you guide treatment. So with baseline testing like this, tracking treatment strategies can give insight into how well a patient may be doing with some of the therapies that you implement. Now, this is an example of a patient who's on a very high dose of a testosterone gel. It was 100 milligrams of a transdermal gel daily, which is a pretty potent dose. Now, it's important to note that generally we see very little evidence of topically applied hormones in the urine. And again, this is due to steroid hormone physiology and topical hormones bypassing the first pass through the liver. So if we see transdermal hormones showing up in urine like this, this is a big red flag. This means that this dose of testosterone is super physiologic. And we can see it reflected in the urine, even though generally we know that urine is provides an underestimation of transdermal hormones. So this patient on this potency of testosterone has an abundance of androgens. But it wasn't just the androgens that were affected here. It's the estrogens too. So you can see how very high doses of testosterone can also cause elevations in estrogens and their metabolites because of that aromatase enzyme. So this is an excellent example of how testing can elucidate how HRT is affecting your patient. So now let's walk through the estrogens neighborhood. So it was, like I said, the aromatase enzyme that caused the elevations that we saw in the case before. So again, you can see by looking at androgen levels and estrogen levels, but also looking at on the summary page, the aromatase activity that's laid out for you there. And like I said, aromatase is, we generally think about it as being upregulated in adipose tissue. There are a lot of other things that regulate aromatase activity, but that is a big one. So the estrogens neighborhood is the most well-researched neighborhood. The unconjugated hormones that we see here, estradiol, estrone, and estriol, they're an important part of the picture, but the real fun is in seeing how these hormones are utilized in the body by looking at metabolites. So the hydroxyestrogens here are representative of phase 1 metabolism, and the methoxy metabolites phase 2, which gives us, if we look at the phase 2 in relationship to phase 1, then we can extrapolate the enzyme activity for COMT, and then also is sort of giving us an evaluation of potential DNA mutagenesis. And it's also allows us to track the influence of HRT or BHRT and how it's affecting metabolism creation, which I think is a really beneficial part of testing metabolites. So let's now walk through this neighborhood. So let's start with phase 1 detoxification. So in phase 1 detox, estrogen is hydroxylated via CYP hormones. These are often called catechol estrogens. It's the OH marker. There's 3 to pay attention to. Now, I mentioned these when we were talking about the summary page, but just to go over them again, the 2 hydroxy markers are generally considered to be the safest, where the 4 hydroxy estrogens have the most potential for DNA damage. They're considered to be most potentially carcinogenic. Then the 16 hydroxy metabolites are considered highly estrogenic. Now, depending on the age of the patient, this may be a good finding or a bad finding. We do know that it could drive carcinogenic potential, but we also know, but I should note, less strongly than the 4 hydroxy metabolites. But we also know that 16 hydroxy metabolites can be helpful for bone density. So this one is a little bit more gray than the others. And then, of course, here we've got it all laid out between 2 and 4 hydroxy metabolites, how they're moving into the methylated metabolites and looking at methylation activity. So now let's talk about some of these enzymes that are important. So CYP1A1, this is the enzyme that you're really going to want to take a note of. It's the one that pushes estrogen towards the safer catechol estrogens in phase 1. So the 2-hydroxy or 2-OH, E1 and E2 metabolites. We want estrogen to move in this direction rather than the 4-hydroxy pathway. I do want to note that we want to be mindful that other toxins are also moving through the system, and they have the potential to turn into even more dangerous metabolites. So things like polycyclic aromatic hydrocarbons, which are cancer promoting. This enzyme also activates aflatoxin and tobacco intermediates, both of which can be carcinogenic. So we still want to make sure that metabolites in the 2 pathway are moving onwards into methylated phase 2 intermediates. We're not just thinking about hormones here, about the estrogen, the estrone and estradiol. Our patients don't live in a vacuum where the only concern they have is estrogen, because all of these compounds are in the body and metabolizing together. So we do want them to prefer the 2 pathway, but we do want to make sure that those hydroxy metabolites are being methylated. So in general, upregulating this CYP1A1 enzyme is what we want. The most famous way to do this is via DIM or cruciferous veggies. I'm not going to go, again, into too much detail with all the ways to upregulate this enzyme, but you will have this slide to refer back to and pull from it as appropriate. Now, to downregulate this enzyme, which would be probably a bad thing, everything is listed here. Now, you're probably going to notice at one point some of the same substances are listed on the upregulation and the downregulation pathways. Initially, this might feel really confusing and contradictory. The truth is, if someone is eating a colorful, veggie and fruit forward diet that is well balanced with good fats and not a lot of inflammatory carbohydrates or things that they're sensitive to, the body will likely utilize these things in the appropriate way. So if we give the body the substrates it needs, essentially colorful fruits and vegetables, there is an innate intelligence in the body that's greater than any medication that we can give, and usually it utilizes it appropriately. Okay, the CYP1B1 enzyme is the enzyme that pushes the estrogens down the 4-hydroxy pathway. In general, not what we want from an estrogen perspective. And this enzyme is more readily found in tumor tissue compared to normal tissue. So upregulating this enzyme is generally, again, not what we want. And we know that inflammation upregulates it. Leptin and insulin resistant upregulates it. So you can see that trying to control inflammation, glucose metabolism, exposure to some chemicals in our environment, all of these things can help to slow the activity of this enzyme. If we're talking about downregulating it therapeutically, there's a lot of research that shows the Apiaceae family is really beneficial at this, but you can see some other things listed here. Resveratrol is a good one, quercetin, because these things show up again and again. Okay, now let's move to the third enzyme here that's responsible for moving some of the estrogens around, and that's the CYP3A4. So this moves estradiol into estriol and estrone into 16-hydroxyestrone. It's been estimated that this enzyme metabolizes about half of the drugs in the market. It's mostly found in the liver, but it can be active in the gut. And the activity of the enzyme varies, but it's affected by health, the environment, hormones, and genetics. Let's look at some of the things that have been found to upregulate and downregulate. So meds that, like I said, so many meds utilize this enzyme. So if your patient is on something that can induce CYP3A4 activity or 3A4 activity, excuse me, that's a typo, then you can better understand how their estrogens are being affected. But you can see here things like St. John's wort, valerian, ginkgo, et cetera. All of these things can upregulate the enzyme. And if you're interested in downregulating it, these are things that can influence that activity. Okay. The 2 and 4 hydroxyestrogen metabolites, the phase 1 metabolites, are then further detoxified via methylation. Now, this is an important pathway because it renders the harmful 4-hydroxy metabolite significantly less active and also activates the protective 2-hydroxy into the beneficial and more active 2-methoxyestrone and estradiol. If these 2 and 4 hydroxyestrogens aren't methylated, they can be converted into highly reactive molecules that can potentially damage DNA. This process, this phase 2 metabolism, has the ability to produce reactive oxygen intermediates, which is an important thing to remember as we move forward. So let's also, now this is sort of the big picture. Now let's take it step by step, because I know this can sometimes feel kind of overwhelming. So we want to think about oxidation versus methylation. So if the COMT activity is working well, it's going to inactivate these catechol estrogens, increase the solubility of them, and prepare them for excretion. We know that these methoxy metabolites are stable and allow these conjugated hormones to safely leave the body. Now, if COMT is not working well, these can be oxidated via CYP peroxidase. And this is where we get quinone and semiquinone formation. And we don't want these because these are metabolites that can cause DNA damage. And so this is where we can assess risk. So in each of the neighborhoods of the HUMAP, After all of the analytes are listed out for you in terms of the amounts found and plotted on this histogram, you'll have a section called the ratios and calculations. Now, I think this is sort of where the rubber meets the road. This is where we can really get an idea of the relationship between some of these markers that's really helpful. So in the case of hydroxy to methoxy metabolites, you can see here we can look at the relationship. Let me see if I can get my cursor over there. Between 2-methoxyestrone and 2-hydroxyestrone, 2-methoxyestradiol to 2-hydroxyestradiol. So the methoxy is what we want. The hydroxy is the more dangerous phase 1 metabolite. So what we're hoping for here is green or higher, right? The more abundant the methoxy metabolites, the better it will be, because then we've got more adequate methylation, meaning these metabolites are being detoxified and less harmful. So in this case, we would see that the estradiol pathway could use a little bit of support. And so methylation support, cruciferous veggies, methylated Bs, et cetera, would be something to consider. So again, if we're thinking about methylation, we can upregulate it with cruciferous veggies, resveratrol, lots of good spices, anything that has a methyl donor. And if these are downregulated, pay attention to the amount of sugar in the diet. Is there an infection? Are they vitamin deficient in some of those Bs that help affect the methionine cycle? So this is all pretty complicated, but some of the simple points I think can help us move forward. So in general here, what we want to do is just help that COMT, catechol-O-methyltransferase enzyme work more efficiently. And then these are just other things that can downregulate COMT activity, essentially environmental pollutants, genetic polymorphism, some medications, et cetera. So if we have lots of estrogen or lots of these unmethylated 2 and 4-hydroxy metabolites, we have the potential for more estrogen quinones. These quinones and semiquinones can result in DNA adduct formation and DNA damage. So one of these studies, the authors state increased amounts of estrogen DNA adducts are found not only in people with several different types of cancer, but also in women at high risk for breast cancer, indicating that the formation of adducts is on the pathway to cancer initiation. And this is particularly true in postmenopausal women. So we do want to try to make sure that they're methylating efficiently, but even if they're not, there are still ways to counteract DNA damage, and two of the best treatment strategies are NAC and resveratrol. The HUMAP reports a marker of oxidative stress, the 8-hydroxy-2-deoxyguanosine, and you can see here in this example that this patient has an abundance of it, which is potentially damaging. Now, I do want to stress that an elevated 8-OH2DG does not equal cancer. This oxidative marker can be elevated in lots of different situations and disease states. In fact, I even did a HUMAP myself when I had COVID, but did not yet realize it. I was sort of in that prodromal phase, and my 8-OH2DG was very elevated. So anything that's causing significant inflammation can result in oxidative damage. So we certainly think about this marker in terms of cancer potential, but I do want to just stress that you can help your patients understand that having an elevated 8-OH2DG does not necessarily mean that they're on the way to developing cancer. So if you find that this is elevated, we do want to try to address the cause of oxidative stress. But there are a lot of therapies that can help, even if you're not able to identify the etiology. And lots of references if you want to deep dive there. So what are some of the advantages of HUMAP to this point? The ability of our lab via our sensitive LC-MS to test progesterone itself, the ability to test DHEA, allopregnanolone, androstenedione, and the estrogen metabolites for the estradiol pathway. Generally, those are not tested because they're found in lower amounts. So the hydroxy and methylated forms of the estradiol pathway for both 2 and 4 pathways, I think is really, really helpful for me to be able to monitor. I do want to also stress that because we are testing liquid urine samples, we're able to get that enhanced sensitivity with our testing, especially for low concentration metabolites. When urine is dried, it has to be reconstituted from the filter paper once the sample arrives at the lab. And this reconstitution process can lead to a loss of polar steroid metabolites and creatinine for some patients. But with liquid urine, we don't have that problem. We're able to process it faster, concentrate it further. We can detect those low-level analytes. And because we have this liquid sample, you can add things like neurotransmitters to a HUMAP test. So while the HUMAP focuses on phase 1 and 2 markers, I do want to note here that it's really important that we providers not forget phase 3, which is elimination. Generally, elimination happens via urine and stool. And so if your patients aren't pooping, they're not going to be excreting all of these hormones and these metabolites. So we do want to make sure that we're keeping an eye on their ability to defecate in a healthy, regular manner. We do know that conjugated estrogens will pass into the gut for elimination, but there's this enzyme called beta-glucuronidase that can break some of the tight bonds that are found between glucuronic acid and estrogen, in particular in the colon. Now, there's some research that indicates it's not just estrogen, potentially progesterone and testosterone metabolites as well. But we do know that estrogen in particular can be cleaved and then reabsorbed. And so being able to monitor beta-glucuronidase activity can be really, really helpful. Now, this activity can increase if the patient is not eating a lot of fiber in their diet, right? Low fruits and veggies, if they're eating a lot of sugar or processed food. So essentially a standard American diet plus alcohol, plus maybe antibiotics, that's a bad combination. So if you're interested in testing for the activity of the beta-glucuronidase enzyme, our GI 360 test does give you that marker. So no matter what you find with your patient, if there are issues with phase 1, phase 2 metabolism, you do want to make sure that you're actually treating phase 3 first. Make sure they're hydrated, they're eating a good amount of fiber, if they're constipated, that you're helping them move that through via herbs or things like magnesium and calcium. So we want to make sure those bowels are moving so that all the good work you'll be doing to support phase 1 and 2, phase 1 and phase 2 metabolism doesn't get derailed at that phase 3. So let's summarize quickly about HUMAP. It gives us a comprehensive assessment of unconjugated hormones and their metabolites. It allows the practitioner to examine what the body has utilized and can give you guys greater insight into alpha versus beta metabolism, phase 1 and phase 2 detox. It's a potential risk assessment for breast health and other disease processes. Allows us to look at the utilization of hormones, whether they're endogenous or exogenous, and can assist with complex cases where BHRT and salivary testing appear to be normal, but the patient still has a lot of symptoms. And again, remember that elimination is the key to any treatment case. So we want to make sure that our patients are eliminating well before we address phase 1 and phase 2. So I wanted to start with this big overview of the HUMAP test because it's still a little bit of a newer test for us. But now let's dive into the neurotransmitter portion, which is really the meat of this lecture. Let's talk about the benefits of testing hormones and neurotransmitters together. Doctor's Data is able to provide you with this unique opportunity because of our liquid urine collection. So when we think about the benefits of combining HUMAP and neurotransmitter testing, it may be of special importance in cases that involve mental health symptoms that came on during a time of hormonal transition. So, for example, an aging male with depression might have low testosterone, or maybe mood symptoms that happen at certain times of the menstrual cycle that can involve neurotransmitter imbalance as well as estrogen dominance. An obvious connection between the HUMAP and neurotransmitter testing is COMT activity, because that is important with both estrogen and catecholamine metabolism. Many COMT variants have been identified that can either slow down or speed up its activity. According to one review, up to 80% of the US population had at least one SNP in this gene. Now, of course, having a variant does not guarantee a certain neurotransmitter or estrogen metabolite pattern. which is why testing can be really helpful here. Now, when we think about COMT activity in the neurotransmitter realm, these are the markers that it will affect: 3-MT, norepinephrine, and metanephrine. And in the estrogens, of course, we're looking at methylated activity. To support a sluggish COMT enzyme, we're going to think about methyl support, whether that's through supplements or foods. And if the COMT activity is overactive, one strategy is to support the MAO enzyme. Now, why is that? Well, it's because catecholamines are metabolized via a two-step process that utilizes both COMT and the MAO enzyme. And so if you find that these metabolites seem to be sluggish, supporting MAO may be a good strategy. People who have MTHFR gene mutations can experience interruptions not only in the breakdown of catecholamines, but also in the synthesis of neurotransmitters that include or that require methylation as a cofactor. So generally, we're thinking about serotonin, dopamine, norepinephrine, epinephrine, and glycine. And that is because, let me get my cursor here, this BH4, this tetrahydrobiopterin, isn't that fun to say? BH4 is a methylation dependent cofactor. So if they don't have the ability to methylate here in these rate limiting steps of the creation of serotonin in the catecholamines, they're likely going to have lower levels on testing. But it's not just methylation that can affect metabolism. We know that inflammation is problematic for neurotransmitter secretion and metabolism, as well as hormone secretion, especially in the androgens and corticoids neighborhood. We also know that insulin resistance affects neurotransmitter secretion and metabolism, as well as androgen secretion, typically androgen excess in females and androgen deficiency in males. And then we know that excess estradiol can slow COMT and MAO activity. It can, though also sort of maybe counterintuitively, increase MAO activity. So really, we're looking for that nice balanced middle ground, right? And then progesterone can actually downregulate COMT gene expression as well. So homeostasis, a nice balance of all of these markers, can be really beneficial to our patients. Stress, of course, is always a consideration. We know that the stress response involves a coordination between epinephrine, norepinephrine, and cortisol. Stress is inflammatory and can hijack neurotransmission. The fight or flight response is a well-coordinated process. We know that norepi and epi are released from the brain as well as storage vesicles in the adrenal medulla in response to stress. They increase segregation of glycogen and triacylglycerol, as well as increase blood pressure and cardiac output. Cortisol is then released to continue the stress response and continues to be released until the threat is over. Until the threat is over. That's the tricky bit, right? Because in our modern world, stressors may just go on and on and on and on, which can lead to some maladaptive changes in the HPA axis and in catecholamine secretion. Now, chronic stress can be a very significant obstacle to cure. It literally shrinks the brain and degrades the blood-brain barrier. Stress can be physiological, mental-emotional, or environmental. And you can see some examples listed here. Remember that excess adipose tissue, especially that abdominal adiposity, that apple shape, is especially inflammatory. And so it acts as a stressor. We know that chronic stress can damage the hippocampus, which in part helps to drive the sleep-wake cycle, which has the potential to damage HPA axis dysfunction. So the effects of epinephrine and norepinephrine may have already been known to you, but are you familiar with the role that serotonin plays in the stress response? In response to a stressor, our body immediately releases epinephrine and norepinephrine, and then moments later, cortisol is released. And all of this works together to enable that freeze, fight, or flee response. But what's not commonly known is that serotonin also plays an essential role in this cascade. So in the presence of stress, serotonin, as well as acetylcholine, but we're not able to test for acetylcholine, so I'm not mentioning it here. As a quick aside, we're not able to test for acetylcholine because it's so quickly degraded, because acetylcholinesterase is so ubiquitous in our bodies. So, but we are able to test for serotonin. So in the presence of stress, serotonin tells the hypothalamus to release corticotropin releasing hormone, which then stimulates ACTH secretion from the pituitary, which stimulates cortisol secretion from the adrenal cortex. So if serotonin is inadequate, these signals may be compromised. Chronic stress will eventually deplete the catecholamines, so dopamine, epinephrine, and norepinephrine. And depletion of catecholamines are closely related to stress-induced performance decline and issues with focus, energy, motivation, and mood. Now, this is a very much simplification of these processes, but when I'm teaching about it, I like to think about there being 3 different phases of the stress response. And these can be important to identify in order to for us to support our patients appropriately, because patients often present with the same symptoms. They'll tell us they're tired, they're depressed, they're anxious, they have trouble focusing, and they have trouble sleeping. However, patients experiencing these same symptoms can be at vastly different phases of the stress response because everyone fatigues at different rates, and depending on the stage of the stress response, your treatments can vary quite a bit. So I do want to point out here so you understand what we're talking about. On the left is a cortisol graph taken from a salivary diurnal cortisol sample. On the right is a cortisol graph taken from a urinary cortisol sample. So remember, in urine, the 2 hours post-waking is the highest point, whereas in saliva, it's 30 minutes after awaking. Because the bladder pools hormones, so we've got a little bit of a later representation in urine than we do in saliva. And then down here is a snippet from the neurotransmitters portion of the test, looking at levels of norepinephrine, epinephrine, and then the ratio between the two. So these are an example of an early or phase 1 response. So generally when patients are in this early stage, we will see elevations in cortisol and elevations in norepinephrine and epinephrine. Now, not always, but generally this is where patients go. This hypersecretion is the first step. At this point, generally people are really efficient at responding to stress, but the sympathetic nervous system isn't designed to stay in this high stress mode continuously for months and months or years and years. So we start to see maladaptation. Now, some people call this adrenal fatigue. That's become sort of common slang to describe what's happening here. But the adrenal gland isn't fatiguing. What's happening is the sympathetic response and the HPA axis are adapting to this constant onslaught of stressful stimuli. So at this point, this maladaptation can result in some of these markers looking high and some looking low. So this is just showing you an example of what we might see in phase 2. The neuro and endocrine systems here are starting to adapt. Now, I have noticed that epinephrine seems to be the last of these markers to decline. I think that's because it is such an important part of the stress response. So you may see epinephrine levels continue to be elevated, whereas norepinephrine and cortisol levels are starting to decline. And then at some point in that late stage where our patients are really depleted and exhausted, here we have what we might call phase 3. Sometimes with cortisol, we call this a flatliner. At this stage, people usually feel pretty lousy. All the markers are low. There are no hard and fast rules governing how people move through these changes, but these stages can just help us think about sort of the way that physiologically patients often move from hypersecretion into hyposecretion, and those maladaptive changes having a significant effect. And so I like to think about it this way because it helps me choose my therapies. The therapies I choose for phase 1 might be significantly different than the therapies I might choose here in this late phase 3. Stress can also affect dopamine and serotonin. Dopamine and serotonin can acutely stimulate testosterone production, but epinephrine can inhibit testosterone production. So essentially what we're saying here is that when there is a significant stressor, the brain and the body will deprioritize sex. So inflammation. This is a really important consideration. Inflammation hijacks so many things, including neurotransmission and hormone metabolism. So the HUMAP may suggest inflammation when cortisol is favored over cortisone. You see increased cortisol metabolites when aromatase activity is elevated, when you have elevated androgens in a elevated androgens in a female, or low testosterone in a male, when your patient is favoring the 5-alpha reductase metabolites, and if there's elevated 808-2-DG. And over the next few slides, I want to show you visually what you might expect to see. So again, inflammation is suggested when cortisol is favored over cortisone. You have increased cortisol metabolites. When aromatase activity is elevated. Here we've got a female with these upper range androgen metabolites and a male with low testosterone. Both reflect inflammation. And then the 5-alpha reductase metabolites. So again, we see them in the progesterone's neighborhood, the corticoids neighborhood, and the androgens neighborhood. And the 808-2-DG. So these are all visual examples of how inflammation may present. Inflammation also contributes to depression and other mental health problems. So on the left here is a list of factors that may indicate inflammation. I think we could add smoking and poor diet to this list, but it's pretty thorough in general. And then there's some mechanisms here shown in the blue boxes that can be affected by inflammation. So you can see inflammation can result essentially in neurotransmitter imbalance, and that can result or contribute to psychiatric conditions in our patients, especially depression and anxiety. Okay, thyroid health. Thyroid issues can affect both neurotransmitter secretion and urinary metabolite secretion. So in the HUMAP, what we might see is higher cortisol and low cortisol metabolites if the patient is hypothyroid, which is more common than hyperthyroid. But if they're hyperthyroid, we might see higher cortisol metabolites and elevated cortisone. With neurotransmitter testing, low tyrosine could impact thyroid because it's a precursor to thyroid hormones. And if your patient is hypothyroid, we might see low dopamine, low serotonin, low GABA, and we could also be seeing the increased toxicity of elevated glutamate. So again, visually, in the HUMAP, one place hypothyroidism could be suggested is in the corticoids neighborhood. We might see higher cortisol and lower, get my cursor, so higher cortisol and then lower metabolites. And hyperthyroidism could result in relatively high cortisol metabolites in relationship to cortisone. So they would favor cortisone, but make good metabolites there. And again, low tyrosine could impact thyroid because the thyroid gland combines tyrosine and iodine to make thyroid hormone. So I want to now talk about some of the sex hormones and how they affect neurotransmitter secretion and vice versa. So I'm going to walk through some of the data surrounding these relationships, but I've summarized them here for your reference, but let's go through them one by one. So if we think about allopregnanolone and GABA, so remember this is progesterone's metabolite, allopregnanolone, which can stimulate those GABA receptors in both males and females. The anxiolytic effects of allopregnanolone are mediated by the GABA receptor, and oral progesterone generally creates more of this metabolite than transdermal progesterone. So giving oral progesterone at bedtime is a great way to treat insomnia, and giving oral progesterone during the day is a potential strategy for treating anxiety. This study indicates that serotonin levels drop in menopause, whether it's natural menopause or surgical menopause. But when estrogen therapy is utilized, serotonin levels go back to levels seen in menstruating women. And there are studies that have looked at perimenopausal and menopausal women who have less estradiol levels and complain of mood and cognitive concerns, but giving estradiol reverses these symptoms. A proposed mechanism seems to be MAO inhibition, which can result in increased metabolism. So here's our MAO enzyme, and if we're inhibiting it, less serotonin will move into the metabolite 5-HIAA, and we'll have more serotonin building up because we've sort of if we slow this, it's like we're damming up this downstream movement. Additionally, estradiol can increase the activity of the tryptophan hydroxylase enzyme. So that's this enzyme right here. So we're making more of it, and we're also slowing the metabolism of it. In women, we usually think about estradiol, but in men, it's generally testosterone that we think of as being the most impactful. Testosterone commonly decreases with age, which can result in changes in mood and mental state. So this bullet point here, the third bullet point, is highlighting a rodent study. They gave testosterone and found that it increased serotonin receptor sites, which resulted in greater serotonin activity and an improvement in cognition, mood, and mental state. Now, interestingly, estrogen also increases these binding sites, but this didn't happen with dihydrotestosterone, that potent androgen metabolite. DHT cannot be converted to estrogen. And so what this suggests is that the action of testosterone actually depends upon its conversion to estrogen by aromatase in these males. So just note that if you've got a male who's dealing with mood or significant mood challenges, aromatase inhibitors should likely be used with caution. Minor fluctuations in dopamine can profoundly alter memory. Estradiol has been shown to enhance dopamine activity and thus affect memory and mood. The production of testosterone is controlled via a specific feedback loop called the hypothalamic pituitary gonadal axis. The hypothalamus secretes a GnRH hormone, which signals the pituitary gland to secrete luteinizing hormone, LH, which in turn signals the gonads to produce testosterone. Researchers have found that the administration of dopamine agonists in rat brains increase the amount of GnRH mRNA by 67%, and that's involved in the DNA replication of that gonadotropin-releasing hormone. Dopamine and testosterone have a bidirectional relationship. Dopamine can influence testosterone, and testosterone can influence dopamine. And if we think about males, an important area of the brain for sexual function is the medial preoptic area, or the MPA. So one study found that microinjecting dopamine agonists into the MPA of rats resulted in an increase of sexual activity. And a different study observed that castrated male rats showed no interest in fornication and no dopamine release in that MPA. But after injecting testosterone, the castrated rats were able to engage in sexual intercourse and showed an increase in dopamine release in the MPA. So to summarize what we just talked about, healthy estradiol levels improve serotonin and dopamine in both males and females, which can in turn improve mood and cognitive symptoms. Allopregnanolone is anxiolytic due to GABA A receptor stimulation, and dopamine-enhancing testosterone secretion in males has been examined in the context of sexual health. And because other studies have identified the role testosterone plays in mood in males, we may be able to extrapolate that testosterone and dopamine are linked. And so both can improve cognition, mood, and things like energy. Excuse me. So in the United States, it's estimated that about 35% of all adults suffer from metabolic syndrome. Metabolic syndrome is a state of sympathetic nerve hyperactivity. This study suggests that insulin and norepinephrine cooperate independently to the development of metabolic syndrome, and both are increased in metabolic syndrome. So the diagnostic criteria are over here listed on the right. Insulin and catecholamines likely cooperate to the development and clinical features of the metabolic syndrome. Insulin seems to be the determinant for the negative metabolic aspects, whereas catecholamines seem to be important for the development of hypertension and impaired glucose metabolism. And then outside of these papers, if we just think about symptomology, we know that working up hot flashes would be benefited from both tests, because we know that hot flashes are associated with estrogen, progesterone, and serotonin imbalance. Anxiety, depression, and cognitive symptoms are associated with estrogen dominance, low progesterone, low estradiol, as well as various neurotransmitter imbalances. And please remember that not all symptoms result in predictable patterns. So if there is the possibility of there being a neuroendocrine component to a symptom or pathology, we recommend that you test both. All right, I know that was a lot of information coming at you today.